Hello everybody. Today I will be talking on management of poisoning in children. Poisoning is a common medical pediatric emergency and this involves multi-organ, which means management should be taking care of all these organs which are involved in different poisonings. So today I will be discussing in general what steps you are going to take when you manage a poisoning case. Basic management starts with the emergency stabilization. Then you identify poison by taking history and then doing examination of the child. Then try to remove all the toxins or poison from the body, and there is administration of the specific antidote for specific poisons. Next, promotion of excretion of poison via different methods, and then supportive management is given to the patient. The emergency management takes care of A, B, C, D, E. A standing for airway clearing, B is breathing, where you use mechanical ventilation. C, assess of circulation, or this is mainly the cardiovascular system. D, diagnosis, then decontamination and using different drugs, that is mainly the antidote. Exposure, E is exposure, E stands for exposure, enhanced removal, evaluation and re-evaluation. A poisoning case requires evaluation and re-evaluation. Then calculate the Glasgow Coma scale, which also needs to be repeated frequently. Now, initial stabilization starts with the airway. So, always consider intubating the victims of poisoning earlier than the other patients, because maximum of the poisons or toxins, they cause respiratory depression. Then breathing, B stands for breathing. You evaluate quality of breathing and give supplemental oxygen wherever needed, and then positive pressure ventilation to the patient. Initial stabilization, now taking care of C, that is circulation or the cardiovascular system. Here you start with the large bore IVSS, then you give bolus of fluid as needed. Then monitor pulse, blood pressure, ECG monitoring is required. Assess the skin color and capillary refill time. You need to see if the patient is in shock or not. Reassess for arrhythmias. Next comes D, that is decontamination, which means reducing absorption of poison in the body. So decontamination is a bit lengthy process, because you need to decontaminate various parts of the body. So we start with decontamination of the gastrointestinal tract, because maximum poison is by ingestion. So for gastrointestinal tract decontamination, there are two steps. One is induce emesis. Second is put the stomach tube or insert stomach tube in the stomach and then do gastric lavage, which evacuates the gastric content. Then use activated charcoal, which removes the adsorbent substances, and then use catharsis. These are the substances which accelerate peristalsis and then accelerate defecation, so the poisons are taken out. Let's start with the emesis. Here syrup ipecac is given in a conscious and cooperative patient. It is most effective if it is used within 30 minutes of ingestion. Syrup ipecac is given followed by intake of 100 to 200 ml of water, and this can be repeated every 20 minutes if necessary. So after giving this, patient vomits out the contents of the stomach. There are some contraindications for emesis. In the corrosive poison like strong acid, strong alkali, you should not do emesis. Caustic hydrocarbon or ingestion of kerosene poisoning, this is also contraindicated. And comatose patients with the absent gag reflex, it is useless giving emesis. So these conditions you do not give emesis, because corrosive poisonings there is further risk of esophageal injury and in a caustic hydrocarbon injection there are risk of pulmonary aspiration. Next is the gastric lavage. It is done in the emergency room and most effective if it is done within 60 minutes of the injection. This removes 31% cases the substance is removed by this method. It is more effective for the liquid poisons only because the intact tablets and pieces of mushrooms, it is not taken out by this method. So this is useful mainly for the liquid poisons. Now come to the technique of putting stomach tube to do these various methods. So insertion of stomach tube is done after lubricating the stomach tube. You insert the tube through mouth or nose and then till stomach you enter. This procedure is done with patient either lying in the left lateral position or with the patient head down position, and try to protect the airway by putting a ET tube, and then aspirate out and save the content for poison analysis. Now start with the gastric lavage. So lavage is done with the lukewarm water or saline 15 ml per kg cycle in and out. You introduce 15 ml per kg normal saline or lukewarm water and then again take it out. So this process is continuous until the return fluid is clear. So gastric lavage being done with the head tilt position, head down position. Indication of stomach tube is when emesis is failed or unsuccessful, then you have to go for gastric lavage. So that time you put stomach tube. Another is for collection and examination of gastric content to identify poisons or analyze the poison. You have to put a stomach tube. And third indication is while administrating charcoal, activated charcoal, antidotes or catharsis. Contraindication for activated charcoal. So in a stuporous, comatose or convulsing patient, you should not give the activated charcoal until the airway is protected. So if the airway is protected with a cuffed endotracheal tube, you can give. Otherwise you should not give, as there is a chance of aspiration. And ileus or intestinal obstruction, you should not give activated charcoal. And if there is ingestion of poorly adsorbed substances, there is no benefit or use of activated charcoal. So those poisonings are iron, lithium, potassium, sodium, cyanide, acids, alcohols and hydrocarbons. Technique to administer activated charcoal is 1 gram per kg introduced via the gastric tube mixed with sorbitol. Sorbitol is a catharsis which helps increase the peristalsis and remove the toxins through via defecation. This process can be repeated to enhance the elimination. Cathartics, they stimulate the peristalsis and then hastens the elimination of the poison. So the cathartics used are magnesium sulfate 10% 2 to 3 ml per kg or sorbitol 70% 1 to 2 ml per kg. Now come to whole bowel irrigation. This is here mechanically it cleans the entire intestinal tract. So here the substance used is polyethylene glycol electrolyte solution at the rate of 25 to 40 ml per kg per hour for 4 to 6 hours you do, or until rectal content is clear. You do the irrigation. The indications for irrigation is massive iron ingestion where intact iron tablets are taken, which is visible in the abdominal X-ray, or ingestion of sustained release and enteric coated tablets like salicylates, calcium channel blockers, beta blockers, or drugs filled packets like cocaine, heroines. If it is filled in packets, so that sort of drug is taken out by whole bowel irrigation. Contraindication of whole bowel irrigation is GI hemorrhage, intestinal obstruction, ileus and comatose patients. Now come to decontamination of ocular or eyes. So here irrigation with the lukewarm water or normal saline is done and washing eyes from medial to lateral should be done. Direction should be from medial to lateral. And skin decontamination is done with water or normal saline. If the oily substances or pesticides are ingested, then use soap water, and then you can shampoo the hair. If there is inhalation of the toxins or exposure via the inhalation, then free flow oxygen is used. Now, use of drugs, that is mainly use of antidotes. Antidote means substances which bind poisons and counteract the effect of poison. Just show the specific antidote for some common poisonings: paracetamol N-acetylcysteine, amphetamine chlorpromazine, atropine pilocarpine, dhatura o belladonna physostigmine, benzodiazepines flumazenil, cyanide amyl nitrite, carbon monoxide 100% oxygen inhalation, mercury BAL, that is British anti-leucide, also known as dimercaprol, heparin protamine sulfate, iron desferoxamine, morphine or opiates naloxone, organophosphates atropine or pralidoxime, warfarin vitamin K, lead EDTA or penicillamine, phenothiazine diphenhydramine, methemoglobin methylene blue, arsenic dimercaprol. So these are the common antidotes for different poisonings. Now come to E, that is enhanced elimination. Increased fluid intake is done so that GFR is increased and then output is increased. Forced alkaline diuresis. Now come to E, that is enhanced elimination. Here increased fluid intake is done, so which promotes increased GFR, so excretion through urine. And forced diuresis is also done to increase the excretion through the renal route. Forced alkaline diuresis is done in salicylate poisoning. Forced acid diuresis, amphetamine. Osmotic diuresis, use of mannitol in barbiturate, quinine or strychnine poisoning. Enhanced elimination is also done by purgative and laxatives, which increase the cut motility and decrease the absorption. And dialysis is another way of enhancing the elimination. Hemodialysis, peritoneal dialysis, both can be done. Now exposure to be done. Take off the clothes and then try to see whether further injuries are or trauma is there, and clothes are even removed to decontaminate the skin. Evaluate and re-evaluate. You need to evaluate, re-evaluate the different vital signs, the source and nature of poisoning. You need to evaluate clinical signs, symptoms, and treat with the supportive management. So cardiorespiratory care is done by maintaining ventilation and perfusion, and prepare intermittent positive pressure ventilation and try to put the child in the mechanical ventilator if required. Then correct the electrolyte, fluid and electrolyte disbalance. If there are seizures, control the seizure by anti-seizure medications. Intravenous fluid to perfuse the child. Treat anemia by giving blood transfusion. Treat renal failure and treat infections by giving antibiotics. Thank you. This was the general management for just a poisoning in general. For specific poisons, specific managements are there, so that I will be talking in my different later classes. Thank you.